Afternoon, everyone, or good morning, depending on where you're located. My name is Melanie Clevenger, and I'm with the School Telehealth Resource Center. Sorry, we have someone that still needs to be muted. There we go. Welcome to the National Telehealth Webinar Series presented by the National Network of Telehealth Resource Centers. This network is comprised of 12 regional centers, as you can see on this map, if I can, there we go, and 2 national centers, one that specializes in telehealth technology and one that specializes in policy. And you can find links to all of these centers. Host, could you please mute that person? Having a little feedback over here. Anyway, you can find links to all of the centers by visiting our website, and it is incorrect at the top of this slide. There is no S before the .org. It's telehealthresourcecenter.org. Today's webinar features Dr. Julie Hall-Barrow. She's going to talk about a school-based telehealth project that her and her team have recently launched in the Dallas area. Dr. Hall-Barrow is the Vice President for Virtual Health and Innovation at Children's Health System of Texas in Dallas. Children's Health is one of the top 5 pediatric hospitals in the country and is utilizing technology to reach children wherever they may be located.
Was that our intro music? Because I liked it.
No, I think that was somebody's ringer on their cell phone. Terry, can I ask you to mute your microphone, please, and Justin as well?
Hello.
Hi there. Can you mute your microphone for us, please?
Oh, I'm not sure if I know how to do that.
Bottom left-hand corner, mute.
Emergent delivery and healthcare mobility. Doris, can I ask you to mute your mic, please? There should be a mic symbol.
Good morning.
Hello, there we go. Okay, if I could ask everybody to manually mute your microphone, there should be a microphone symbol.
Transfers, since you called
Mr.
me.
Downey, if we could ask you to mute your microphone, please.
Tell her the next time, just call me directly. Use my extension is 7552.
You recognize his
All right,
voice?
it's 398-7552. All right,
How did that happen?
Well, you're muted, aren't you?
Okay, we're just asking everybody to manually mute your microphone, please, those of you that are signed into the webinar. I still have several that have their mics open. If you could close them, please. All the background noise makes it difficult for our speaker to be able to share. Dr. Halbero, if you want to go ahead and share your screen now, we can go ahead and get started.
Okay, we will get that started. Let me, well, where is my power? There it is. And we will get that moved in here. Okay. There we go. So today we're going to talk about school telemedicine and improving access and outcomes. And I am excited to be able to tell you a little bit about Children's Health. We're two service hospitals located in Dallas and Plano, Texas. We have 50 specialty and subspecialty at our centers, and I put on here 19 pediatric primary care locations, but now we have 20. So we just opened an additional one in the last couple of days. We have a strong community health offerings, telehealth, of course, that we're going to talk about today, and also research. A couple of important things I thought is important for you all to know about the school telemedicine and why virtual health is a major arm of our system. Is 1 out of 9 children in the U.S. actually live in Texas. And of those, in our specific service area in Dallas County, 29% actually live in poverty. 18% of our Dallas County children are uninsured. And the overlaying factor of this is only 31% of Texas physicians accept new Medicaid patients, which is increasingly decreasing each year. There are 50,000 children in North Texas with asthma, and as you can see, lots of other indicators and how we're trying to improve children across our state. I'm excited to have 2 of the main leaders of our school-based telemedicine program with me today. I have Danielle Wesley, and she leads our school-based health programs, and Dr. Stormy Williams, who is the medical director for the school telehealth program. And of course, myself, and we have a large team that support us from both IS, from outreach to EMR management and training and education. So with that, I just want to give everybody a quick picture of what our virtual health platform looks like and how we've incorporated school telehealth. So we have traditional hospital-to-hospital telemedicine, which includes our tele-ER, tele-NICU. We do internal telemedicine with neonatology and subspecialty, as well as neuroimmunology. We have traditional store and forward activities. We do have a lot of office, clinic, and school programs that we'll speak specifically to. And then we have launched a lot of home-based programs, which include remote patient monitoring, mobile applications such as our Asthma Propeller app, as well as our asthma app itself. And then we just launched Children's Health Virtual Visit, which is our direct-to-patient platform. And with that, we're going to move straight on into our school-based telemedicine program, and I'm going to turn it over to Danielle Wesley to talk a little bit about why school telehealth.
Hi there. So we love the school telehealth model, and for us in our neighborhood, we also know that schools as well as faith organizations, through the lenses of looking at our families, have indicated to us that they believe those are trusted partners. And because of that trusted partner relationship, we also know that that's where children are spending majority of their day. So several years ago, when we felt the need that it was important for us to launch our school health strategy, we also understood that linking health and learning was going to be important for us as a growing health system. We wanted to certainly see greater outcomes in the areas of decreasing absenteeism in our schools and also decreasing emergency room utilization, but also important value propositions for our schools in terms of linking health and wellness to learning, as they also look at opportunities for increasing academic achievement. So we know that the link between health and learning from lots of research is certainly something that we wanted to see utilized and hopefully piloted in many of our schools across the Dallas market. One other thing that we kind of looked at from a perspective of why schools, we started doing some geographic mapping of most of our school districts in our area, and really the propellants of where we might have shortages of pediatrician offices and also family practice offices. So that really led to critical opportunities for us to look at access. How do we create systems of access for our children and families that really give us right place, right care, right time opportunities. And so schools obviously was a likely provider and a likely partnership in that endeavor. We actually started in 2013, and interestingly, the relationship in which we had with one of our local preschool environments really led us to actually piloting in a preschool site. But quickly we knew through our lessons of engagement in the preschool environment that is not necessarily the most ideal environment to be in as we look at the type of outcomes that we were ultimately trying to achieve. Some of the learnings obviously is that in some cases preschools may not necessarily have what we identify as our patient presenter being a school nurse. And then the other factor to consider in terms of geographic location of where to place school-based clinics is really the age of the children. The preschoolers were not necessarily very verbal in terms of their ability to explain how long they may have had a symptom or where the ache or pain perhaps may have been. So quick learning from the preschool market really led us to where we started our really expanded telehealth market pilot in our 2014 and 2015 sites. And that's when we went to traditional schools looking at primarily the primary space. So we were interestingly in a meet the neighbors state and trying to determine who would be a likely partner. So we were more in a sales mode, I believe, last year and trying to identify who would be ripe and likely partners for this partnership. So we looked at, again, our geographic mappings, looked at utilization data from emergency rooms, look at cross populations of where there is shortages of access for healthcare, and that really led us to specific markets, specific geographic neighborhoods as well. One of the other things that we also talked about in terms of where we launched for 2014 and 15 was looking at opportunities to engage in multiple different types of school venues. So we were able to pilot in an urban setting. Also, we chose 2 what we call rural areas in some of our rural counties, and also wanted a kind of a across the board metroplex feel. And so we also chartered with a large charter network that actually spans into about 3 or 4 different counties. So
Excuse me, can I jump in here real quick? Can I ask you to move a little closer to your microphone? Yes. There's a lot of feedback. Thank you.
Is this better?
Sounds better so far. Yes, thank you.
Oh, okay, perfect. So again, those many different markets allowed us to really get some good data points for our true launch, which was 2014 and 2015. And also, I'll let Julie talk about the technical support end of it, but there were a lot of learnings from the training and education perspective that we used to really kind of look at some process improvement opportunities. And then we have a fully dedicated telemedicine technical team that also assisted us with all of our installations, all of the training and support that goes around the actual equipment themselves that we deploy. Yeah. Anything else you want to?
Yeah, we'll talk about some of the technology things in a minute, but it really was allowed us to get lessons learned. How do you roll out such a large program? What are the resources needed really behind it for the day-to-day operations? Dr. Williams, would you want to add anything from those first lessons learned?
Yes, so I would say one of the largest things that we learned, or biggest lessons that we learned, is that having a dedicated medical team also was very important. When we were involved in the preschool model, the providers who were there, and even part of last year, were seeing patients in their clinic, live patients in their clinic, and then we're also being pulled to see patients in between for the preschool students. And it really wasn't a good model for the actual in-clinic site because, as you know, in a typical medical office, there are things that happen all day, and sometimes you get backed up and patients are waiting there, and then you also have patients waiting for telemedicine. So that was probably one of the biggest lessons we learned. And then also having kind of a backup or support system for the medical team. So not just one provider was needed, even though it wasn't ramped up to have a full patient schedule, we also needed a backup person for various reasons. So we've expanded, and we'll talk about that a little later.
That's good.
So our 2015 expansion really allowed us to do some things in terms of process improvements. And again, based on those lessons learned, it also created a great amount of demand in our market for schools that actually were interested in wanting to actually be sites for telemedicine. So in 2015, we were able to bring on an additional 30 schools, which brought our total school volume to 57, and that was inclusive of 5 additional school districts. So our numbers for 2015-16 school year are 57 schools. Perfect. So where are we headed? We also are in current discussions with one of our large districts here, which over 250 schools alone. And that conversation started even last year of what we might do with some of our large districts. So we are also in discussion to bring some additional sites in January 2016, and also a major rollout of the large district in September of 2016 as well. So as you can see, we are ever growing and continuing to expand the telemedicine model across the Dallas-Fort Worth Metroplex in several counties here in Texas. To that end, it also looks like there are opportunities in which we can actually expand the scope of service. So we are proud to say that we started with acute care first. There was such a large interest and appetite for us to also look at opportunities in behavioral health. So we are also looking at opportunities to launch teleschool behavioral health, in addition to expand the scope of services on the clinical setting to include disease management, in addition to some additional expanded education around asthma and diabetes as well. So that's what we've got going on as we launch into next year and the next several months with the expansion of our telemedicine program.
Yes, last and not least, as we do this, obviously we built a large program, but we really can't be in every school district in Texas, nor do we want to, because that's not where their regionalization of healthcare is. And so we are looking to expand with other health systems that are wanting to do telemedicine in schools and offer our network services and expertise for that. So although we may not be going to additional school districts outside of our North Texas corridor, we will be powering up other individual groups to do that as well. So that takes us to what the technology is. People always say, well, what type of technology you use? We do use a traditional telemedicine card in all of our school-based settings. We have each unit networked to our network, and all the data is encrypted, of course, and HIPAA secure. And all of our cards include both a stethoscope, a general exam camera, as well as an otoscope. And so it's real important that all that information is on the card. Everyone is trained the same. Again, from our IT technical support, is we don't want to envision what type of equipment are you using, that when there's a problem that it's standardized throughout our system. So we use this equipment both in our school-based setting, but we also use it in our traditional telemedicine setting, as well as in some of our outpatient clinics. So we're trying to be consistent in terms of support and education for all of our patient presenters, our patient providers, and also the technical support team. So that gets us into the operations. And so we'll all kind of take a role in this, but really just one of the important part is that training and compliance of the telehealth presenters is very important here in the state of Texas. So all the schools are a part of and approved to be approved medical sites. The caveat is that you do need to have a telehealth presenter if it's the first time that you're seeing that patient. And the word that they use here in Texas is face-to-face. However, it doesn't mean live or touching you face-to-face. It has to be live audio and video, and include some of those peripherals as if you would do it in a practice setting. And so all the presenters go through intensive training and education, and then each member is taken through a compliance checkoff list. Not just our patient presenters, but also our providers. So we try to make sure everyone is on the same page, and we keep that for our compliance office. The training will go around telemedicine. We'll talk a little bit about workflow, and we'll talk about labs and follow-up and those type of things when we get to Dr. Williams, really taking you through the day in the life of a telemedicine provider for a school-based clinic.
And so, and so on the school side, obviously, there has to be an agreement in place. And so we actually have done a really good job of kind of outlining and identifying the legal terminology, in addition to the liability terminology and insurance coverage information into those school contracts. And so we are in an agreement to be able to provide medical provision services on those campuses. And so the one thing that protects us is obviously the agreement. But the secondary thing is that we are looking at care provision, so that also obviously means parental consent. So through the course of working with our campus administration, we do a very good job of trying to just marry this concept and this process into the day-to-day documentation and forms of registering for school and filling out your forms for immunizations. It's just, again, one additional thing that we have our parents fill out, and that is the consent form for telemedicine. So all of our parents enroll their children and give us parental consent to be able to see them during the school day through the presenting of the school nurse for any of their health illnesses.
I will say we do have that one-stop number for all of our presenters as well as our providers, and they can call that number, and it's a simple phone tree. One, if you need a telemedicine consult. Two, if you're having a technical issue, and then it is parented off in either direction. And so Dr. Williams will speak a little bit to how that flow happens when she's working with our patient registration folks.
Right. So a typical day or a typical patient would present to the school nurse, and if she deems appropriate, she would call our 844 telemed number to make an appointment, just like you would when you call your primary care physician's number. Once she talks to the registration staff, the staff here make sure that we have those consents on file, and they register the patient into our electronic health record. At that point, the school nurse is actually assigned an appointment time, so that the provider then knows what time to reach out to the school nurse. Then at the appointed time, the exam starts or the visit starts, so that the provider then calls the nurse, and the nurse is there with the child. Usually we will have a parent on the phone or sometimes present. And then sometimes the parent gives the school nurse the ability to perform the exam without their presence. But we go through a typical visit using the collateral equipment on the unit, as well as the live video and audio that we mentioned. And then a diagnosis is typically made, instructions are given through the video, but then we also prepare what's called an after visit summary, where we summarize what the treatment plan was and what we discussed in that visit, so that the parent will have something tangible. The school nurse, we fax it to the school nurse, and then she in turn gives it to the parent when they come to pick up the child. So it's really a streamlined visit to make sure that, again, the children can stay in school as long as possible, and that there's kind of taking out that middleman or that day or two of waiting to get an appointment outside, or even going to the emergency room in the evening.
So this is kind of the point where I'm going to ask Dr. Williams some questions, and Danielle, and these are the typical questions we typically get asked. So I'm going to try to preempt maybe some of the questions you all have, but at the end, please feel free. We'll be able to take any questions. So Dr. Williams, how can you see a child through telemedicine and diagnose them?
So it is live video. So that's one thing. I am laying my eyes on that child, and we have the equipment to be able to do a very good head exam. So we can look in the eyes, the ears, the nose, the throat. We can also listen with a stethoscope to the heart and lungs and hear it real time. And with the great technology that we have, I'm able to see a tympanic membrane to diagnose an ear infection almost clearer than I can in office with a wiggly child. So it's actually very, very good technology, and I trust it completely.
Right. So you mentioned an ear infection.
Mm-hmm.
So how do you get that child medication?
Great question. So luckily we have an electronic health record. So we actually utilize e-prescribe. So before the patient is even seen by the provider, as a part of that initial consent and enrollment process, we have the family's pharmacy already loaded into our electronic health record. So it's a matter of typing in the prescription and hitting send, and it goes directly to the pharmacy. So again, that parent can pick up their child, and on the way home, drop by the pharmacy and pick up that prescription.
Great.
I had a question.
No, oh, I had a question for you.
I have a question for me too.
Okay.
So Danielle, what happens if the child has a PCP or a family practice doctor or medical home? Great question.
That was going to be my question.
So school-based telemedicine is, again, it is a tool for school nurses to use while the child is in school. Most of the communication that we give to our families is that we want to make sure that that information is connecting back to the child's medical home. So consenting to give your child access to telemedicine during school does not eliminate the need for a child having a pediatrician or a medical home. So the after visit summary that Dr. Williams talked about is really our way to connect that document that talks about what happened during the course of that visit, and also any other instructions in terms of follow-up. We want to make sure that gets back to the child's medical home. So that can be faxed to the PCP, that can be emailed to the PCP, And our last resort, obviously, is getting it to the parent in hopes that that will get back to the PCP if we don't know who the PCP is for that child.
Okay, so I have another question for Danielle. So we've been trying to get school telemedicine into our schools locally, but the nurses just say they're too busy. How did you make that happen?
Great question. What we typically try to do with our engagement strategy is really try to make it a part of the workflow that's already happening for the nurses for that day. We actually do a very good job of actually having what I call boots on the street, and that is actually a nurse-to-nurse support person that can really talk to the nurses about the types of kids that they're seeing, the symptoms that they're presenting at the clinic, if those are perfect and appropriate opportunities to refer for telemedicine, looking at the numbers of kids that they've sent home over the last 30 days and what were those cases for. So we really do instruct and train and support our school nurses and really give them full wraparound support of being able to be the champion in their school for this program. It's not saying take on additional work, but it is trying to look at how you classify and how you look at those kids for what they're presenting for in a different way, and hoping that, and most of our nurses are very receptive to that and have truly been champions in their clinics and on their campuses about this program.
Great.
And I'll just add to that quickly. Some of the feedback I've received from some of the nurses are that they feel empowered by this tool, because they aren't feeling like they just have to send every child home that comes to their office. But then they also have those children whose parents cannot get them to a primary care office or aren't necessarily following up on things. So we are able to treat some acute illnesses that may otherwise go overlooked. So they actually are very receptive to it and feel quite empowered by the program.
So Dr. Williams, you talked a little bit about that. So tell us a little bit about what you actually see. What are your top 3 diagnoses? How complex can you get in a school-based telemedicine program?
That's a great question. So right now it's cold and flu season, and whenever kids are in school, to me, it's cold and flu season. And so right now our primary complaint is actually respiratory complaints. So a mixture of upper respiratory infections as well as allergic rhinitis or allergic symptoms. We also see quite a bit of rashes and just different skin ailments, including abscesses. And insect bites, especially when school first started, we were still in summer. So we can do pretty complex things. We had a great case last week of an ingrown toenail, and the child was limping and they were getting ready to send him home. But with proper instruction and a prescription for antibiotics, the child is much better. We did a follow-up exam the next day and then 2 days later to make sure that he was doing better, and he is completely resolved of the symptoms. So we can go pretty complex with this as well.
So as you talked a little bit about flu season coming on board, tell me a little bit about how you're expanding or your thoughts about expanding, because as we know, with school telemedicine, you can't swab a kid's throat. So how are you approaching that in your school-based telemedicine program?
Right. I can't physically swab a kid's throat, but I can train nurses to swab a child's throat and nose. So our goal for this year is to expand into point of care testing in the school setting. So we are in the process of establishing labs that are extension of children's, but then also lab sites within the school itself, and teaching those nurses how to collect specimens properly for rapid strep testing and also rapid influenza testing. So we hope very soon here to be able to roll those out and pilot a program where we are testing children for strep and flu, and we'll be able to not only treat those kids who are positive, but then also to reassure the parents and families of those children who are negative.
And I just want to add on to that this was actually a lesson learned from our pilot of 2014-2016 last year, 2014-2015, excuse me. Our nurses were indicating to us that they were seeing classic symptoms of what could potentially be strep and also flu, but having to send kids home. So we looked at that data, we listened to our nurses and understood that feedback and looked at it as an opportunity area. We also got communication back from one of our schools where they actually had to send an entire school classroom, including the teacher, home because of flu-like symptoms. The teacher was positive for flu, and the next day there were multiple children in that classroom that were having those symptoms. So an executive decision was made for the entire school classroom to be sent home. So we certainly want to see cases in which, if we are on that campus, we can make a difference, and what are those ways in which we can truly use our program to make a difference. And so that is actually a perfect example of partnership with the school and how we make those process improvements with our program.
So now I'm going to ask myself a question. So one of the questions we get all the time is, well, can any doctor do telemedicine? My answer is no. Although they all maybe have the ability to be on video, it really does take a physician who understands that this is not the same as your clinical practice. And so we are so lucky to have Dr. Williams in our practice, because not only was she in the pilot and actually learned the lessons learned with us, but she actually is the champion. And I can't stress that enough. If you don't have a physician collaborator that's a champion, it will just be much harder. So I encourage you to find that physician who thinks technology is an advantage to your practice and not a disadvantage. So that's one of my lessons learned there. All right, we're going to go ahead and try to get through the slide deck, and we also want to leave everyone some opportunities, but we did want to talk a little bit about what makes school telemedicine visits successful. So between Danielle and Dr. Williams, we want to kind of address a couple of these items, and then we'll move on.
Yeah, so I always say, telemedicine, especially in the schools, is not about installing equipment in the school nurse's office. That is just the start. The real journey is about making sure that there is school engagement and buy-in from all the way from the superintendent down to the actual campus administrator. In most cases, that's a principal or headmaster. So in our case, we do a lot of engagement around that campus in terms of trying to identify parent champions in the school. Connections and making sure that we have visibility in the school for the program. We want to attend PTA meetings. We want to attend open houses and teacher nights, etc., with those kids and those families to continue to talk about the program and the benefits of the program. So really, I would say that the number one success factor is how do you infiltrate and engage on the campus so that it just becomes a part of the culture of that campus. And I'm going to tell you that each campus is treated differently because they are not the same. So that is the very first rule, for our perspective, a guideline. I would also say that the nurse readiness. We have some criteria in which we believe are opportunities for success in terms of school size, in terms of the school makeup, in terms of the enrollment of the student population. But we also know that the nurse is the true champion when it comes to telemedicine and making it successful. So we look at the tenure of the nurse. We also look at how that nurse has wraparound support at the campus level. And then also we just do our part in making sure from a training and competency perspective, she is ready and she is empowered to be able to make the decision for telemedicine for those students on those campuses.
Yeah, and I'll just add in there, Dr. Williams wants to add something too. So it's real important. Every nurse is a little bit different, just like the schools are. So we have some nurses who we've trained, we've done their entire training in one day. They do their mock the next day, their competencies the third day, and they are seeing patients. We have other nurses who take more time. And so just like with student learning, nursing learning is a little bit different. So we don't abandon any of the nurses. Not only do we do an initial training, but it's an ongoing process throughout the year. And Dr. Williams, a little bit of the things that we do is a program called the Nurses In, which is a continuing education that we offer through the program. But also we do a nurse facilitator once a month with the providers.
Mm-hmm. And I just want to echo what both of them are saying, that the nurse readiness is probably, I think, from the medical side, one of the most important factors as well, because they're putting, as being the presenter for the telemedicine visit, they're being put in a position where they typically haven't been. Most school nurses aren't looking in ears or checking throats or listening to heart sounds. So there's a lot of education that goes into that to make sure that the provider is getting everything that they need, but then also that the nurse feels comfortable in doing these visits. So nurse readiness and buy-in is huge. And like she said, teaching is ongoing. We have a newsletter that will come out every month that offers tidbits of information on where to place a stethoscope, how to get a good angle on an ear exam, things like that. So it's not a one-stop training. We have a great training team and technical team that are there for them whenever they need it. But like she said, we hold their hands throughout the process to make sure that they know that we are all accessible.
So the other area that we get asked a lot about is, so what are we looking at in terms of data? And so one of the things is our main goal is to increase access to these kids in terms of getting health care. And so we hopefully, by doing these non-traditional endpoints, that we're getting access to the kids who may not get it. So that's one of our biggest goals. The second is we're looking at outcomes. So I'll talk a little bit about, as we mentioned when we looked at the data initially, where to go. We're also looking at that data ongoing. One of the specific things is, are we reducing ER utilization for those low acuity visits? That's high on our list. That's also high on our funders that actually, this program is a part of the 1115 waiver program here in Texas, which gives us funding initially to actually set in place innovative, disruptive healthcare programs. But we have to see, are we making a difference? The goal being, of course, can we reduce the cost of these children where they're typically getting those acuity visits, which are high cost institutions. The other outcome we're looking at is absenteeism.
Yeah, absolutely. There are a couple of things, just for, again, if we're marrying health and learning together, we absolutely want to make sure that these kids are being set up for success. We'd love to see that this program, in cases where they may have stayed home or may have been sent home for an illness, that this is actually helping to decrease absenteeism for our schools. We all know that schools revenue is about a child being in a seat. So it does resonate in terms of the value proposition of having telemedicine in those schools, so that we can make sure that we're doing our part of keeping kids healthy and keeping them in school and learning and instruction. And lastly, I would say that a longitudinal, very long-term objective is that we want to see that we're doing our part to keep them healthy so that their academic outcomes are increasing. We are looking at ways in which we could measure standardized testing in terms of correlation to health and things of that nature. So we're very excited about the future and how health is actually helping with healthy children and wellness on our kids and on our campuses.
Perfect. I don't know if we have time, but Melanie, I don't know how much time we should leave at the end. I do have a video, but I think it's the longer video. Do you think we should play that?
How long do you think it is?
It's 9 minutes.
That's going to take us pretty close. We're going to need to allow probably 10 minutes.
Hey, why
for
don't we'll
Q&A.
give you the link afterwards that everybody can that could go watch it.
That will be fabulous. If you can send that link in the chat
We will.
box, that would be great.
Great. So we just had some highlights of the program this year. So in September, for example, that's when school just started back. We saw 155 kids seen through telemedicine. We trained 65 nurses. They were trained and completed all of their competencies. We have created a live dashboard for technology and visits because, again, we're looking at those outcomes. So we can immediately know how many visits were done that day, by which schools, at what time, which provider did them. So we're really looking at those items daily, as well as what are the things we're seeing. We talked a little bit about we're expanding to that strep and flu testing at the point of care, and we have integrated some of the asthma and obesity disease management, and we'll continue to grow that as well. The other big piece is communication with the PCP or connect with the PCP, and I'll let Dr. Williams speak to that. Many of the children, although they may have an assigned PCP, they may not have a relationship. So Dr. Williams has worked closely with our social work department.
Absolutely. So we actually set up a unique relationship, a referral for kids who say that they do not have a relationship with their primary care provider, or we found that they may list a doctor that they saw 3 years ago and haven't been back and moved away, so it's not a convenient office to go to. So with this relationship we have with our social work department and what we call our patient navigators, we can refer both for children who don't have insurance, so they need help with applying for Medicaid or CHIPS or commercial insurance. And then we also have it set up so that these children can also be referred for primary care placement. So we have a system of clinics within Children's that we can refer to, but we also have resources to look outside of our network of physicians to refer them to a primary care provider that is close to them and more convenient.
Yeah, it's been essential. As you can imagine, this program is not set up to bring everybody to downtown Dallas. It really is to create health resources in their own community. So the biggest thing we're always asked, and we've left that for last, is, well, how are you going to sustain this program? It sounds really good, and we do think it's really good, but we did need a sustainability model to go with this. So we worked really hard over the last year and a half with the Texas legislature and was able to pass House Bill 1878. What that means is the school-based telemedicine clinic was already an approved site, and it was a billable site through Texas Medicaid. The problem was, in order to bill, you had to be the PCP on record. And as you can imagine, Dr. Williams is not the PCP on record for every child in 57 schools that we have spread across North Texas. And so we want to be able to bill for these actual visits. And we do have a parity law in Texas for some areas, not all, for private insurance and third-party payers. but for the Medicaid side, we do. And so we wanted to be able to have a law that would allow us to be able to bill. So we were very successful. Jody Laudenberg actually sponsored our bill, and we were able to get this passed, in which it now allows any provider to bill in a school-based telemedicine program, which is a great boon for us, but it's also an opportunity for our colleagues across the state to also implement telemedicine. So it's a really great opportunity that we now not only can put this program in place, but after the 1115 waiver, we don't all pack up and equipment is just going unused because we can't sustain it and we can't employ our physician and nurse practitioners to keep this program going. So our government relations team was essential in getting this together. And if anybody wanted a copy of that House bill, again, Melanie, we could get that out to them.
Great.
So I just wanted to talk a little bit about challenges. So if you've never started a telemedicine program or you're thinking about starting a school-based telemedicine program, it's a little different than what I would call traditional telemedicine because we don't own that location. The employees are not, the nurses are not our employees. They are someone else's employees. So I just want to encourage you, as you're putting your program together, sit down with your compliance, legal, risk, and privacy officers and encourage them to help make your plan. Many times people say, oh, they just don't get it, or they just say no. And that's typical when you say, here's what I want to do. Take the approach of saying, we want to do school-based telemedicine. How can you help me make that successful? So our compliance team has been great. They've given us lots of direction. Sometimes when we thought we couldn't do something, they said, absolutely, we could do it if we just changed something about the way we wanted to roll it out. Our legal team has been essential with Danielle and working with those contracts and making sure that everyone's covered and everyone understands what the roles and responsibilities are. Again, Children's Health is providing the telemedicine platform and the resource, but they have to own that program. It's got to be Denison School District's telemedicine program, not Children's telemedicine program.
That's right.
Security and the HIPAA piece is very important. Again, those telemedicine consents, we're working very closely to make all of our consents online. That's been a huge step up as well because, as you can imagine, dealing with a lot of paper is not conducive to being able to keep everything controlled.
And one other thing about the HIPAA is that schools are bound by a law called FERPA, and that is their essentially protection of student level data information, as we are bound by HIPAA. So making sure that, their terminology and how they're protected and how the health system is protected is also important with that legal aspect.
I would even like to have Dr. Williams jump in here too, because as you can imagine, she also has rules and regulations that she must follow under some health rules. And how does that happen over telemedicine? And so you've had some great conversations with our team as well about how you address some of the issues. You're bound by the same things that you're bound by out there in your clinic, correct?
Oh, absolutely. So HIPAA is important, but there's also other legal things that we have to deal with. For example, we talked about mental health. It's not necessarily something that we have to get parental consent to discuss or treat, although we aren't necessarily doing behavioral health now, but in the future, that will be important for us to know. And then also when it comes to sexual health, we can talk to children about sexual disease prevention without a parent's consent or even without them knowing what we're talking about. So those are some of the laws that we talk, things that we have discussed, but HIPAA is just the biggest thing, making sure that the nurse has a private area for us to talk about, that there's not the secretary sitting next to her, or that the office isn't open to people walking by, so that the child actually feels like their information is being protected as well.
And I think that's important too from the provider side. So we're very lucky that our providers, they absolutely love telemedicine. So they actually don't sit in a clinic all day and do telemedicine. They're doing it from whether it be here at our administrative offices or at their home. So we make sure that their home's HIPAA compliant. They all wear their coats that identify who they are. And as you can see behind us, we have a Children's Health logo, of which they also have. So it makes everybody feel very comfortable that this is who I'm speaking to, and they're verifying who they are, as well as the nurse presenter is verifying who that patient is. It's very important. The last item I have on here is accreditation. Again, if your hospital or health system is accredited by Joint Commission or others, people are always asking, well, how does this fit in? We work very close with the accreditation that this sits outside of our Joint Commission because, again, it's coming from our clinic-based folks and schools. So I would, again, though, have that conversation with those folks in your institution. So we're going to wrap up our part right now, and we've got our names down there in case you have any additional questions. But I'm going to actually, I think, quit sharing my screen.
Actually, if you'll hold off on that, that give everybody a chance to write down your email addresses, and we're going to give everyone a chance to start asking some questions. If you want to hover at the bottom of your screen, and that'll pop up a menu that will give you an option to click on the chat screen, everyone, and you can type in your questions, and then I'll read those to Julie and her team. I've already got a few that were sent while you were presenting, and so I'll go ahead and start with those. First one was when you were showing the pictures of the cart, what specific technology carts did you use? AMD, Philips, Costco?
Mm-hmm. We initially started with a global med cart, and we've now standardized throughout our whole telemedicine system. We actually use Avizia, and we actually are a Cisco network institution, so we utilize all the codecs, and then we actually use Cisco Meraki's on all the carts so that we're able to manage them from a distance, which is very important, as some of our schools are a good distance away from our technical support.
Okay, great. Lots of information today. Next question. Let's see, where did we go? Has there been any conflict or restrictions by school policy on what extent the school-based telemedicine program is the only medical care available to children? And is the program robust enough to accommodate this need? Sorry, I just read two different questions because somebody...
Oh, that's okay. And probably Dr. Williams and I will both tag team this, but I want to talk about the real challenge around school-based telemedicine as it relates to the medical provision is that, again, the parent has to consent. One of the other things is that the parent also, through the consent form, it does say that they don't necessarily have to be present. So that's also a part of the language by which they sign a consent form allowing their child to be seen. We never say that that is the only provision of service. It is something that is available to the family and children. Not every parent signs up and enrolls their child for telemedicine. That's the one thing. So it's an opt-in, opt-out program. And the second part of that question that I wanted to make sure to point out is that there was a mention about, I just drew a blank. Yeah, the policy. So we actually say in all of our literature in terms of the brochure and all of our FAQ documentation and any communication to the parents, we follow all school policies. We have had in some cases where schools wanted to change the policy around when they can send kids home and what fever, 102, 101, etc., because now they have access to services. So our program does not sit outside of the school policy. We absolutely have to follow the school policies, but we have had, in some cases, the districts went back and changed their policies because of this provision that was allowed in their school setting.
And for our perspective, as far as the providers go, we are definitely limited by the video screen. So we can't do everything. And we have had some cases where school nurses may reach out to us for things that we don't necessarily feel comfortable treating through video. And for those children, they are referred out, and we make sure that they have means to not just get there, but actually have a means to be seen. We don't just say, oh, follow up with your PCP, but we use our patient navigators to make sure that they have a means to pay for those appointments, and if not, to get help applying for those insurance cases. And we've even been able to find free clinics nearby that we can send children to. So we are limited in what we can do, and we realize that, and we communicate that. So anything that we feel like isn't necessarily what we would like to see, even though the school may want us to see them, we always have that ability.
And as you know, not everything is telemedicine appropriate. I think that really starts at the beginning of our training with the nurses. So we're only called on those things that really we can help. Now, sometimes once in those conversations or seeing a child for something that was telemedicine appropriate, it does sometimes expand out to needing those other services. But we really just try to focus on that triage point to allow those nurses to send things that are telemedicine appropriate.
And at one point also, we all had a parent actually give us a comment and feedback. The child was a case in which they had to say, 102 fever, the child has to go home. But at the same time, the child was enrolled in telemedicine. So while the parent was on their way to the school, the visit had already occurred and the medication was already waiting at CVS, Walgreens, Walmart. It doesn't matter to us, but wherever that family's preference was. And so it really expedited the process and not tried to really put the burden on the parent to try to figure out how they can get their child into an urgent care center or make an appointment for the PCP the next day, etc. So we do find that schools are using this program to really set the stage for getting care quicker, even in cases where they have to actually send kids home.
Okay, next question. Has there been any conflict or restrictions by school policy on what the school nurse can perform? When you add labs such as rapid strep, does each school then need a CLIA certification for waived testing?
Yeah, so we are actually in process of writing that policy. The policy then will also have a procedure specifically about what the school nurse is required to do and how she's required to do it. All of the school nurses will receive training, and then that documentation will actually be a part of the addendum to the agreement for all of our school sites.
So every school may have, every district will have that addendum, and they'll choose to participate in it or not.
Right. And then we have actually applied for CLIA certification to perform wave tests in those sites.
Okay. Next question. How are technical issues handled and who is responsible for resolving them?
Love it. So that number that we talked about, that 1-800 number, when they press 2, there's technical support. It goes straight into our help desk team, who then gives a warm handoff to the IS video telemedicine team. So that's sent right to them and at time of issue. And then based off of what the trouble is, we do 1 or 2 things. Number 1, we handle it because it's a network issue. Many times we know of the problem before they do because we can see the unit go offline. So either someone's gotten into the network room and has unplugged something, or housekeeping has come in and unplugged the network jack, or things like that. If it does require us to go out, our technical team responds to that school, usually same day. If we can't do same day, it may be the next day. But we usually, I would say 90% of the time, we're same day service and we resolve that issue. If it's above and beyond our technical expertise, then we reach out to our partner, and our partner team then helps us get that resolved. We keep a lot of the parts on hand. So we did recently have an issue with a network board, and so our provider said keep an extra network board on your team in case you need it. So having a great resale partner is important as well as the manufacturer. As you can imagine, we've ordered a lot of carts, and so it's very important that they be on time and fastidious with us in our request.
Okay. We have way more questions than we have time for, so I'm just going to randomly grab some out of the list here. Are nurse practitioners allowed to do school-based telemedicine?
Yes, absolutely. So it's myself on our team. It's myself as a medical director, and then we have 2 nurse practitioners who are full-time telemedicine providers.
Yeah, and in Texas, the state regulations, absolutely, State Board of Nurses recognizes nurse practitioners in their role, and they're still practicing, of course, within their scope. And so it's a great advantage to you and your programs from a cost perspective to utilize nurse practitioners.
Okay. What kind of model along those lines could you implement if the school system only has 1 nurse between, say, 6 schools?
We actually do have nurses that are, they're the licensed RN, and actually we look at them as kind of float and have authorization for multiple schools. In some cases, we have trained a backup person like an aide or a part-time RN, or even in some cases they have MAs that may be in those school settings. Some of the information that they can obtain is triage level information and do some of the initial assessment at the time that the nurse is being contacted so that she can come back to the campus and actually do the presentation for the consultation. So we work with those campuses where we do find that there is 1 RN level, that she's got multiple campuses that she has leadership over, and we work a model of having her some backup in those cases on those campuses where they can actually get things ready for a telemedicine visit to happen.
Okay, great. I have another participant who's asked 2 separate questions, or sort of 3, but I'm going to ask them all together. Is this appointment documented in a single encounter in your EMR? Does the RN document in the encounter at all?
No.
And what is your appointment type and length for these visits?
Those are great questions. So, oh goodness,
Yes.
I remember yes,
Yes.
for 1, no for the second. So yes,
We have 1 encounter in our EMR.
we have 1 encounter in our EMR for a telemedicine. And to answer the second question,
Does the nurse document in
so
the
they do not document, but they have an intake form that they fill out so that it's their vitals that we are putting into the system. So we actually scan that into our electronic health record, and then we can transcribe it into our electronic health record.
And if you need it, you verify it. So if you feel like it's not probably, let's do that again. Maybe the child was hyper, the child was scared.
Absolutely. I did that this morning on a patient where the pulse came in a little low. I wanted to recheck it, so I had her do it in front of me. I counted because I was listening to his heart, and I was able to put in the pulse. So yes, we do all of the writing into the electronic health record. The nurse actually has no input into that at all.
And the last part is around what we put in. So it's recorded as a telemedicine visit. We built this into our EMR, and all those things have a GT modifier for billing.
And I think they were asking about the length of visit. Yeah. So right now we are scheduled at 30-minute visits, 15-minute to 30-minute visits. And it just depends on the comfort level of the nurse as well as the provider.
She's done them pretty quick, I will say.
Awesome. Awesome. Okay, next question. Will you incorporate diabetes into your chronic disease management?
Yes. So we're working right now on a diabetes. So of course in our virtual health world, we have an asthma app that we're encouraging our health nurses. So of course, Dr. Williams and her team, if they have a child that's asthmatic, they mentioned the asthma app. The second part is we're creating a diabetes sick day app, which will allow children who have diabetes to help manage. Again, a big part of our thing is transitioning children from pediatric care to adult care, owning their health. And Danielle talks about that a lot, becoming a partner in their own health care. And so we'll have the diabetes sick day app that will also be able to be used, but we'll also be able to help some of those students that have diabetes and need more of that intensive one-on-one education. We'll be able to be taken care of through telemedicine.
Interestingly, we get a lot of questions around non-compliant adolescents at the high school level. So that's been a huge win for us in terms of the difference we can make through education and monitoring with our teenage population.
Okay, great. I think this will be the last question, and it's two of them. Do you have a triage document specifically developed for telemed appropriateness? And also, are PAs allowed, physician assistants allowed to do telemed?
So PAs, again, are allowed to practice telemedicine in Texas, and I won't speak for other states other than I can tell you the ones I've worked in, but they can. And then the earlier part of that question was,
do we have a triage?
Do we have a triage? So we have developed forms that are pertinent to our telemedicine program. And again, we don't try to dictate always, because again, we want the nurse to practice within their scope, but we also want the physician to practice within their scope. If during that consult it's not appropriate, that conversation's had, that feedback goes back to mom and dad. But what's nice is they are able to give them a recommendation. This is not an ER visit. This is not an urgent care visit. This is follow up with your primary care doctor and let us know if we need help in getting you to that. So again, it's a great opportunity to guide kids and create that collaborative care model that's missing many times when they show up at the ER, because it's not their job to make sure it's continuity of care. Their job is treat and treat, as we would say. Same thing for urgent care. Many times those are pop-up urgent cares that aren't communicated in the community. And so this really is a good model to allow those kids to get continuity of care where they may not have gotten it in the first place.
But to the question specifically around triage, the triage form that the nurses are filling out is actually kind of the reason for visit and what they're presenting with. And also it tends to give a little bit of medical history about what medications they're on and any of the things the doctor needs to be aware of prior to actually having the telemedicine consult performed. So it's a little bit of both in terms of the additional assessment prior to visit, in addition to the case of the day and why they're presenting and what their vitals are.
Awesome. Okay, well, again, we have many more questions that we didn't have time to get answered. But Julie, can you throw your slide up real quick again? Do you still have that open with your email addresses? That way they can either contact you all directly, Dr. Hall-Barrow or Dr. Williams or Danielle. And also, of course, the Telehealth Resource Center is here always to answer your questions. If we don't have the answer, we will definitely find it for you. That's what we're here for. Thank you all for joining us today. This has been very informative, in my opinion, and I believe that there's a whole lot more that we can all learn about this. We have these webinars, the National consortium of telehealth resource centers, we have these every month, generally the third Thursday of the month. For November, it's the 19th, and it is regarding palliative care through telehealth, and it is being presented by the Southwest Telehealth Resource Center. So be on the lookout for that. And we have a survey that we would love for all of you to take for us. Let me get to that point. Why is it not moving? There we go. That is not a link, but if you can write that down, I'll leave that up there for a few minutes, just so that you can give us ideas about how you enjoyed this webinar, what kind of subjects you might want to see in the future, and that way we can do our best to cater to your wants and needs.
What about the video that you were going to give us a link to?
Yes, we are going to put a recording of this webinar on YouTube, and the link for that will be available within a few days at our national website, which is that telehealthresourcecenter.org.
No, that's not that. I don't think that's the video. You mentioned you guys skipped showing a video because you were running out of time.
Yes, that is correct.
Hey, it's Julie. I'm going to send that link. It's also on YouTube, so you'd be able to get to it. I just don't have it with me. I don't have it up right this second. So I'm going to send that to Melanie, and she can make sure it's maybe on a last slide that you guys could access.
I will actually, I can send an email, a distribution email through Constant Contact and get it out to everybody that got notification of this webinar. So, and I can put it on our Facebook and LinkedIn pages as well. All right, that is everything for today. Thank you everybody so much for joining us, and I hope you all have a great weekend.